Talk about fractures. I think this week you're talking a little bit in general about injuries and accidents, and I think you get a whole lecture on child abuse, which I'll just touch on. Obviously, pediatric fractures is a long topic that we could talk years about. I think what I wanted to accomplish was just trying to get you guys some basic information, understanding some principles behind it, because I think that's one of the keys to taking care of these injuries. I think over time things have evolved where it's kind of just easy if someone has a fracture just to send it to ortho. But as you'll see in private practice, or again, discussions just with patients in general, kind of understanding some of the basic principles is key. And then obviously on your test, understanding some of the kind of most common fractures, because they'll have you have to pick the right answer. So we'll start with just some statistics. I can get it to go. And so we'll talk about statistics, like I said, different ones, some overall management things, and specific types and pitfalls that we don't want to miss. And there's a whole book on this for fracture management of primary care. Obviously, to manage fractures, you got to know a lot more about them, but I think sometimes the important thing is figuring out which way to go with them, understanding that the x-ray is not going to necessarily just give you the treatment plan. A lot of people, I think, order x-rays thinking that, well, if it's broken, then I know what to do, and if it's not broken, then there's nothing to do, when a lot of times it's much more complicated than that, as we'll talk about near the end. Sometimes the x-ray ordering can throw you off, so we got to make sure we're thinking the right thing and then get the x-ray to help confirm or not. One interesting fact that my son really likes is that you're born with a lot of bones, and then you end up with less bones. So we'll talk about how that relates in here too. So fractures account for about 15% of all injuries in children. 50% of boys, 25% of girls will experience a fracture sometime during their childhood. Obviously, boys happens more often than girls. The rate increases with age, as you can see in this demographic. It breaks down the difference between the non-physeal versus physeal ones. Talking about where those injuries are. And again, age-wise, it kind of increases, you can imagine, as they get stronger, faster, and more likely to hurt themselves. But the distribution is there for all ages. And so, as we'll talk about, there's kind of a different trend. The most common sites, you'll see different things, but obviously the radius, ulna, hand, where they're falling on that Fuchs type injury, where we talk about fall on an outstretched hand. And then you get less and less with some of the distal lower extremities, but still common. We'll talk about some of these. So in one survey in California, they asked the residents basically that graduated, what are some of the things that you wish you learned more about, and sports medicine orthopedics was second only to the economics of pediatric practice as the area that was least comfortable, and the second highest area of increased emphasis. So it is something that obviously a lot of places you just don't feel comfortable, because it's you only get an hour on lectures. But I think understanding some of these basic principles will help you kind of understand. And luckily, kids' bones are different, and they're actually sometimes easier in some ways, and then obviously have more complexity in others. And this is just kind of demonstrating some of that, where you get thick joint cartilage, which you can't image on x-ray. As we'll talk about, ultrasound sometimes is a better way to assess these and then get more information, such as joint effusions and things like that. You get that thick periosteum, which helps with healing. And so it fractures easily because of certain things, but then there's simple patterns, so it breaks more cleanly, we kind of say, versus where adults, it kind of shatters and there's pieces everywhere. The growth plate is something that we always have to key in on, because again, the growth plate is something unique to the kids. And so I always try to teach the students in my lecture that anytime you're reading an x-ray, you've got to always talk about if there's open growth plates or not, because that, one, puts in a differential, two, is something that tells you a lot about the healing time, and then three, can be where you miss some fractures, because you don't know if that's the typical pattern or not. And then just remember that ligaments are stronger in their case, so the bone fails. So this, again, we'll talk about as an example where this is, again, an injury where you got to think about how kids are a little bit different, where instead of tearing their ACL, they might avulse the bone off. So again, going through some of these in a little bit more detail, again, understanding the growth plate area where there's a lot of remodeling. And then this is where too the growth plate injuries can cause deformity, and then the fractures may lead to like problems with the growth also. So that's where you get where the growth plate almost like slips off. So that's one injury type. And then because of that increased changes in the bone ratio, sometimes you get more bending instead of breaking at times too. And so we'll talk about that. And then again, less comminuted fractures. So again, a key word sometimes in describing these fractures, sometimes you just get these little tiny buccal fractures where the tension and compression happens. And so these are key as far as understanding the difference between these type of fractures, and therefore the management will be a lot different in these scenarios. And like we said, the cartilage is something that we got to understand as part of it, and you can't evaluate that. So that's where there can be some cartilage damage that causes pain, but the x-ray, again, will not help you with that always. So understanding and taking that into consideration when you try to think about treating these patients. And as we'll talk about some in the elbow, you can see this is where non-ossified, this picture of the elbow, you don't see a lot of the bones because they haven't ossified yet. So understanding that change over time, so that way when you get an x-ray, you know what to expect. And when you see an x-ray like this, it's not as much about the bones being broken or not, but more about the alignment and the placement, because all the cartilage is what you can see, not the bones themselves in the elbow. And here's just another example of that, where you can start seeing where it looks like there's a loose piece. And is that loose? Well, that's again that non-fully ossified part. And then over time you can get it where you start getting these pieces, but those pieces themselves can slip and move. And so that's where it does make it complicated. Understanding this too, I think, is important, because not all radiologists know how to read these. So anytime you're suspecting something, sometimes getting an overread and not just saying, oh, well, the x-ray was read as normal, and understanding again that you can have an injury that's not a true fracture as such, and it's not going to show up. Again, the periosteum kind of holds things in place and helps kind of keep things in tight, and sometimes it'll keep it from moving as much, and then helps with the increase in why kids can heal faster. And then you got the different age-related ones. Again, infants tend to have more diaphyseal fractures. Children get the metaphyseal fractures, the supracondylar fractures that you've probably heard about. And adolescence gets more of the epiphyseal, physeal injuries. And again, this is just in general. So again, kind of understanding this pattern. So when you have a kid, you know where to look at. But obviously they can cross over and aren't mutually exclusive to those. A better blood supply helps where you don't have to worry much about delayed or non-unions like you do in the old people. So the physeal injuries account for about 25% of all fractures, and it's again more in boys, more in the upper extremity, like we talked about, where they're falling on it. They heal well and good remodeling, but growth may be affected. So this is where you don't want to mess it up. So understanding these is very important in the different types. Have you guys heard of the Salter-Harris fractures before? Because I think this is one of those where this is almost always on the test somewhere because it's so PEDS specific and something that's so easy to know that they like to use these as your guide of, do you understand it? Again, understanding the types is also important because of which ones require more evaluation and more treatment. Does anyone remember which ones we're less concerned about or more concerned about, and why?
Any of the ones involving the growth plate could potentially require surgery. So you'd be less concerned about the ones not involving the growth plate, like type 1 and 2.
But yeah, I guess you're saying growth plate, which they all affect the growth plate, and maybe what you were trying to say, you were right in that type 1 and 2 more the joint line, and so type 1 and 2 don't involve the joint line, and type 3 and 4 do. So you can see where that articular surface is off, and that can be very problematic for long-term healing, because if that doesn't heal quite right, then you get it where that's not going to work, like in the ankle, as you can see. So you're exactly right, where type 1 and 2 often don't require seeing an orthopedic surgeon. 3 and 4 would, to evaluate the movement over time, and those are you're more closely watching. And then type 5 is more of a crush injury. So I think the one type is where on the test, a lot of times I'll talk about type 1 fractures. Understanding the difference between type 5 and 1 is more the crush versus just straight through. Does anyone remember the way to remember the different types? The mnemonic?
It's Salter. So I don't remember. S stands for like straight through, essentially. A is above, L is below, T is through, and then ER is it's erase or.
Good. Yeah. And that's usually, I think of ER, like you're going to the ER because you jumped out of a car or car accident or something like that. And so you're exactly right. The word Salter, straight through, above, and this is, again, remember that it's above the joint or away from the joint. So you could flip this. So if I had my radius and it's a fracture through the radius and then it's coming down, that's not technically above like this, it's flipped, right? So it's away from the growth plate, like, or from the joint line, like we were talking about, away from the articular surface, so above the joint in one way. And so that's where I see some people get this flipped up when they show a picture of a radius or a finger, and it's at that area that's looks a little bit different than this. But yeah, so these are, again, very important. The most common type is, again, they'll show you a picture and have you just say, and of course it'll have type 1 through 5 as the answer choices. The other big thing is sometimes they'll just want you to understand that the differential is in here, where as we'll talk about in a minute when we get into some cases, if you have a kid that falls and has pain, but again, the x-ray is read as normal, understand that that doesn't mean anything about, because you can't see type 1. So that's not going to show up on the x-ray. And so they're going to, again, just say normal x-ray, but that's where in your mind you should think, oh, this is a 10-year-old. He has a growth plate in his distal radius. He's tender over that. Therefore, he has a Salter-Harris type 1 fracture. And so often on the test, I want you to do that because, again, the management and treatment of that, we'll talk about, kind of gets lumped into some of the other ones where it's, you don't have to worry about it moving around. This one doesn't need to be referred to an orthopedic surgeon because all you got to do is immobilize it. So a simple brace splint will do the trick. But then understanding too that it's going to last more than just a little contusion or sprain, where this might last a month or so. And so understanding those differences is important. So I put this in because I think, again, thinking through when you see a fracture, understanding this is all the radiological, jargon that they use. And I think if you don't really understand this well, it's hard because then they'll give you some of these. And then these are also things that is very helpful for you to be able to say, sometimes not the exact, 25 degrees of angulation, but understanding what angulation is, understanding the appropriate angulation, because this is where you can look up on things like ortho bullets or up to date, and they'll give you, well, okay, I got this fracture of a boxer's fracture. What type of angulation am I allowed to have in that? Because at some point, that's where reduction surgery is needed. And so understanding that if these fractures aren't shortened, angulated, displaced, then we're often dealing with stable fractures that only need to be splinted, and therefore they don't urgently need to get in to see anyone as long as they're splinted, because we're not discussing surgery or reduction with them. And so I think understanding these a little bit, again, also describing these to a surgeon, so that way if you have a patient in your office, you can call them and give them some educated information without them actually seeing the x-ray, because you can say, hey, it looks like it's shortened. And that sometimes is like, oh yeah, of course, if it's shortened, then I have to fix that. And so understanding these, and obviously they're not as black and white and easy as this is on the screen. And so again, knowing the exact angulation, sometimes you wish the radiologist would help you. Often just basic radiologists are just going to say fracture, but this is where being in close contact with a radiologist is helpful, because then you could ask them, okay, what do you think about how much angulation? And then again, they're not going to tell you that one's too angulated or that one needs surgery. They're just going to tell you a number. And then again, you can look that up and see if that number is something that needs to be treated differently. Does that make sense to everyone? Any questions about kind of that? And again, this is where you can use these terms on top of the types of fractures. And so we'll talk about some of the types of fractures also, and going through that. Again, that's where, because if they don't have a lot of those, you can accept more angulation and displacement in kids. And, some people joke about, if the two bones are still in their body, they'll heal back and remodel over time. But that's, again, age-wise changes, maturity level changes. And so understanding these little bits of things. Now, the one big thing in this is the malrotation alignment, right? So this is where the bone breaks, but then twists at the same time. The body can't remodel that, but it can remodel a slight angulation, but it can't do that. And so that's where, when you talk about hand fractures, I don't know if you remember, or some of y'all worked with me, but a lot of times what you want to do is look like straight at them like this, right? To see if their fingers are twisted at all. The other thing is have them bring in their hand down and see if they all point straight, right? Where if one of them looks like this, where it's like hanging out that way, that again probably means it's going to need to be fixed, because that a little bit amount of rotational malalignment is going to be permanent and not remodel. So that's again where often we'll go in and reduce those, and sometimes that's where you look at the pattern of the fracture, and we'll get into like the spiral type where it slipped off and twisted some. So this is just showing you the remodeling, so you can see how that bones are barely touching each other, shortened, that, and then over time they healed pretty well together. This is just, again, showing that how over time what it tries to do is fill in at one side and then take away the other side, so it can straighten over time. So this is where, again, the most common one that we deal with is like a boxer's fracture, where you get this and it's tilted down just a little bit, but then the body can remodel by taking away the top and adding more on the bottom, and it kind of straightens it over time. But again, some of you have probably seen me ultrasound a kid and ask him if he's broken his hand before, because we see that little bit of tilt to it. And that's, again, where your body can make up for that. So again, and then over time, it can align it pretty well. So again, there's a lot of factors deciding on whether or not it can remodel. And this is, the most important one is years remaining of growth, because it gives it more time. And again, like we said, there's little pieces of the puzzle, the planes, the physeal, the growth potential adjacent. And so this is where sometimes the kids are almost done growing. So then you're going to say, well, there's certain areas that just don't remodel as well. That, again, is the specifics that orthopedic surgeons have to know and understand. But at least if you kind of understand this basic principle, then it helps you through and understand what we're going for. Again, this is another example of a bad fracture that heals and remodels itself and kind of puts itself in its right place over time. So I did want to go briefly over some of the ideas of where, because I think this is where understanding when you need surgery is important, because again, obviously we're not going to be doing surgery, but understanding that these are the indications and then that therefore definitely need to be seen. And then you'll see that these don't include just basic fractures a lot of times in kids. And so this is obviously open fractures because we're dealing with a lot of different pieces, fixing it right, repairing it to prevent infection. Like we talked about those intra-articular fractures. Always doing a good neurovascular exam, because this is where if we start getting into vascular compromise, compartment syndrome, those are where, again, having someone that can deal with that urgently is very important. And then fractures that aren't reduced by closed reduction. So some of y'all have probably seen me try to reduce some fractures and then we just can't get them aligned right, or it doesn't want to go. And again, this is where they can come in and add a little bit more help. And so obviously casting is the most common fixation that we have. So this is an example too, where we're putting on that ability so it can't move anymore, and then it can remodel and fix. You've probably seen some K wires done. So this is where they go in and try to hold put it back into place and hold it there. But then they can come back and take these wires out by just pulling them out. Then there's the nails, putting in more elastic ones, where they're trying to align those bones up. Screws. These, again, understanding these a little bit, understanding that they stay in most of the time, but they can cause some pain over time, because we see a lot of these kids where they had this surgery at somewhere else and then they come in saying they have ankle pain. But being able to evaluate these, understanding where they're supposed to be, helps you a lot. Plates, same sort of thing. Sometimes these look crazy on x-rays, and if you get one, years later, they look really crazy. Like, what was the surgeon doing? It looked like he just like drilled everywhere. And again, just understanding these, I think, are helpful for when, and then some of y'all probably might have seen these X-fixes where you're trying to do open fractures and really align it well and manipulate it over time. So some of the things to really think about when you're going into these fracture possibilities is the diagnosis is made by history, exam, and imaging. So again, X-rays are not perfect. They're not, they're never going to be like the end all be all. Understanding that we need to review those because we know more information than the radiologist. So if you think there's a fracture or a site that you're worried about, reviewing the X-ray is a very important step. And then again, a lot of residents have reviewed some of the X-rays that I've seen that were read as normal, and then they, I pop it up in front of them, and then they read it as abnormal right away. And that's, again, one of those things where you can't let normal X-rays fool you, because they can miss stuff. But also, again, like we said, they do not exclude non-displaced physeal fractures and these little tiny fractures that can make a big difference. And so we always say treat the patient, not the X-rays. And it's better to over-treat a sprain than under-treat a fracture, right? So this is where, again, your plan might be, let me get this X-ray to see, but you've already decided to treat it because you're worried about it, not, okay, let me send you for an X-ray. The X-ray is normal. Oh, have a nice day. And then we've missed a fracture that needed to be splinted. And again, we can get into fracture management and understanding that one of the main treatments for pain is immobilization. So that's where, again, it doesn't matter if it's fractured or sprained, we want you not to move it. So here's a splint that can help provide that. Did you guys have a lecture on like tumors and stuff with fractures? Or bone tumors? Have you guys had one of those? So obviously understanding malignant tumors is something that I'm definitely not an expert on, but what I always want people to understand is if it starts sounding weird, this is where getting an X-ray you can always get me by saying I'm going to get an x-ray to look for a tumor, because anyone with more pain than you expect on just tiny injuries, you worry that pathological fracture through a tumor. So again, your history can be the injury causes pain that you normally never had. So a lot of times we see these as like chondromas that are like coming off, and then they get hit, and now there's no soft tissue there. It's just hard where the tumor is. And then you'll sometimes see something like this where you get this history of trauma. She's got a little tenderness, but she's got this periosteal reaction. Does anyone know what this would worry you about? And not, again, the classic.
Is it Ewing's?
Yeah, so good. So Ewing's would be definitely what you would, and this is just where, again, some people might see this and say, oh, you got hurt, you broke your leg, it doesn't look that bad, you're good to go. And then you realize 2 months later it's still tender, and then later on it looks like this. And so now more of the classic Ewing's. And so that's where you don't want to forget that these tumors can sometimes present in oh, I banged my shin really hard and get crossed over. And so just kind of, I think sometimes you've got to realize too, you're going to miss these. So just because they're not going to show up yet, but that's where always kind of telling patients, okay, if this continues past 2 months, then we got to redo this because it could be something like this underneath, that type of thing. So good. And I do think you guys definitely got a lecture on non-accidental trauma. Is that right? So again, I'm not the expert on that, but again, this is where in every circumstance, you gotta be at least keeping that in the back of your mind, and where you start getting multiple fractures. Obviously, some people are just unlucky. On the various stages, like they always talk about, mismatching the injury, I think is really big on some of the stuff I've seen, where it's like that couldn't have happened with what you're saying. And then obviously there's some that just stick out. Like I'm sure that they talked about these corner fractures. I don't know if they went over these. These again are where sometimes you see these and they don't look so suspicious, but these type of corner fractures only tend to happen when you get so much force that the kid themselves can't really generate. So these are kids that have gotten really pulled on or moved in a way that is abnormal for their type of movement. So anytime you see these corner fractures, let your spidey senses tingle a little bit and ask more questions, because these are, again, not a typical pattern we see for basic injuries. Again, these buckle handle type fractures, where you start getting them there near the pattern where the joint itself has moved a lot. So unless this kid jumped off something really high or things like that, you get into these corner buckle handle fractures. Is something you gotta worry about. Femur fractures, obviously, when they're not walking, again, very common. But say you got a 3-year-old or 2-year-old that comes in, the mom or let's say a dad brings him in and says, I don't know, I've been watching him all day and I don't know what happened, but he just started not wanting to walk. Nothing happened. And on your exam, you see he's tender over his tibia, and then you get this x-ray. So what do you see here? And what are you guys thinking? Can everyone see the fracture at least?
Spiral fracture.
So it looks like a spiral type fracture, good, because of the way it's coming up through, right? See if I can get my laser pointer. Can everyone see that? So when you think spiral fracture, what automatically thinks, or what do you think about?
Some sort of twisting and possibly abuse.
Okay. So this test question, they usually put something like, what's the next appropriate step? And in that they'll put cold DSS, but they'll also just put them in a long cast or splint. And so does anyone know what this fracture is?
Is it the green stick fracture?
So green stick is remember green stick is, and I have an example of that where green stick is like a partial break but more bending. And so a green stick is again, ped specific type of fracture that needs a little bit more care because instead of just a crack, it has a lot of bend. So then you start worrying about the bone not being able to heal right because of green stick. So this is not a pattern of fracture, more than a diagnostic. So this is where the answer on the test would actually not be call and report them for child abuse, because this is a common fracture seen in 2-year-olds learning to walk.
Toddler's fracture.
Yeah, so
Right.
this is a toddler's fracture. So this is that one where, again, knowing this is very important, because again, this looks like a pattern of abuse, like you said, because it's spiral, because it's the story is going to be he didn't fall. This is just knowing that this pattern is a common one. But again, if you saw this in a 8-year-old and the dad was saying he doesn't know what happened, now you're worried. Or if this happened in a one, and then the first question should be, does this kid walk, right? And then normally, and if the dad's like, no, he's never walked, then all of a sudden that's a whole different problem, right? So it's like, well, something happened to cause that. But 2-year-olds that are walking, they fall in just a way that their bones just kind of twist just right, and it causes the spiral pattern. So this is called a toddler's fracture. And again, like we were saying, comes along with all these basic things. And usually on the test, they just kind of want you to know that this is a possibility, and don't go just call DSS and report and say like, yep, definitely it. So say you have now a three-year-old that presents to the ED after complaining of his elbow pain while playing with his older cousin. His cousin was holding him up by his hands, and he was helping him play Superman. So he's kind of like holding him up and throwing him some. And then he comes in saying his elbow hurts and it's not wanting to use his arm. So what are you thinking about here?
Nursemaid's elbow.
Nursemaid's elbow, good. And what makes you think that?
The traction
Mhm.
type.
So what would you do for him?
There's debate on whether or not you get an X-ray, but then the reduction is the
Yeah. So and this is where, again, it's very important to think of through your history. Also think of worst case scenario, say, okay, he was doing the traction and holding him up like that, but then he did throw him and he fell right on his elbow. This is where, again, your physical exam, understanding the history, understanding okay, if it was broken, what would I do anyway? And so this kind of gets into that whole idea of trying to put the pattern in your mind and understand that the X-ray is not necessarily going to help you. So just waiting for them to go order the X-ray tech is busy, takes a while. They're going to have to manipulate his arm, which is going to hurt.
Gabe here in NICU feels strongly about superpronation.
Treatment, just do it. Yep. Okay, good. And so this is where if you again, everything in your pattern says you think it's the nursemaid's elbow, just go ahead and try to reduce it, right? As we sometimes talk when talking to the students, I try to say, this is where a ultrasound in the ED is super helpful, because you can just throw the ultrasound on real quick and it gives you a lot of information. But this is where the classic thing, and the test question would say, just go ahead and try to reduce it, right? Because this is nursemaid's elbow. And so you got the superpronation flexion, where you're trying to, again, understanding it's the radial head subluxation, because they got pulled out. And so you'll often feel resistance and a pop. And then the kid will use it immediately. So this is where doing it and then handing them, doing it just right, where you're holding one hand and then you hand them a popsicle and see if they reach out and grab it. And then you've treated it, you're good to go. And then explaining that it might happen again in the future, and then telling people not to play Superman that way, at least, is important. But this is where too, we're understanding things like dislocations, subluxations, that we want to go ahead and treat those. Sometimes we don't necessarily need an x-ray because say he did break his elbow a little bit, well, he still needs it reduced if you can tell that he can't move it at all. And this is again where this one just being so classic that if you can get this story trying to reduce it, you're not going to get in trouble for trying to reduce it and then getting the x-ray if it doesn't work, that type of thing. Does that make sense to everyone? But say you do get a story that, okay, well, maybe at first, but then the dad was like, no, the last one was he threw him and he fell down and hit his elbow. And then you get an x-ray and you see this. What do you guys see and thinking in this situation?
Fat pad sign,
Supracondylar fracture.
supracondylar fracture.
Perfect. So definitely fat pad sign, right? So this is where we get into fat pad. And then which one is worse to see, the posterior or the anterior? 50-50 shot. And which one?
Anterior.
Which the anterior is what?
Worse.
Normal to see or not normal?
Not normal.
So the anterior you can see sometimes, but that's where you get the sail sign that you might have heard about, or if the anterior gets pushed up and away. So just remember the posterior has a place to hide. So it usually sits in this fossa back here. So when the posterior pops out, that's when you worry about that there's a bleed inside. And then that is what's called the push the fat pad. And so this one, a supracondylar fracture would be very common. This one is actually a little radial head fracture right here. You can see just a little crack. And again, very hard to see. And this is where, again, though, that you have this as kind of giving it away. So you got the posterior fat pad, anterior fat pad. Again, a lot of cartilage. You won't see a lot. This is where looking at the alignment is very helpful. But anytime you see this, this is basically what's happened. Is so just always remember the posterior has a place to go. And so when there's a fracture, like you were saying, a supracondylar fracture, or any fracture, you'll have this hemarthrosis that pushes the fat pad off the bone, and then it's easier to see it on an x-ray. Again, ultrasound wise, you can throw the ultrasound on there and see a raise of it. So this is what I like to do a lot. So this one, you get a 12-year-old that comes in, there's a bicycle accident, shoulder pain, he's pain with moving his shoulder. You feel some you see some bruising, some swelling of his clavicle, his point tenderness. And so you get this x-ray. So what do you guys think about this x-ray as far as what would be your, like, how would you describe it? And then what would you do about it? And again, using some of the terms like we were saying, because this again is where you're going to look up the difference between these type of clavicle fractures and these type. And so then that's where your plan comes in, because you're able to say it's this type of fracture.
Middle third, non-displaced, angulated.
So is it displaced?
No,
Okay, good. So it's not displaced.
non-displaced, but angulated.
Yeah, a little angulated. And this is again where you could say, is that the kind of the normal angle of the clavicle? So this is where it looks pretty, it doesn't look straight, but the clavicle doesn't go perfectly straight, right? And so this is where you can say it's not displaced. And so it's not like one's hanging up here and one's down here. And then you got that, like you said, it's in the middle, which is the better ones to have. So those are all helpful for deciding that what would be, does this person need to see an orthopedic doctor?
No.
No, there's really no reason. And so that's where, again, I mean, it's not wrong to send them to someone, but this is where what the wrong thing would be is like, oh, I'll put in a referral. They see me a week later. And then I'm like, oh, well, you haven't been doing anything about it? And they're like, no. And I'm like, well, how's it feeling? Well, it hurts pretty bad. Okay, well, now you're 1 week past the point where I would have treated you with a splint for a week, a sling or something like that. And And so it gets into that weird where you've actually worse treatment by sending them to an orthopedic surgeon. So this is where, again, understanding that you guys treat things way more complicated than this. So don't sell yourself short. If you can say all that stuff, then this is way easier than some of the stuff you guys treat, where just put them in a sling until it doesn't hurt to move it. And then obviously following up is where, again, sending them to an orthopedic surgeon to decide that is certainly reasonable. But I would argue that, again, getting an x-ray in 3 weeks to see if it's formed a callus, palpating it, range of motion, those sort of things are all key. So again, a common thing, often you'll feel like a bulge or some crepitus there and tenderness. Again, don't forget about these type of fractures can cause pneumothorax, hemothorax, vascular compromise. So don't forget to do a good distal radius or distal neurovascular exam. So this one's a 10-year-old that presents for forearm pain. He fell on a skateboard. He braced his fall with his hand. He's got some pain, no numbness, tingling, weakness. Again, very important to always say on everyone, because you're looking for that compartment syndrome, vascular compromise, distal injuries. He's tender over his distal radius. And then so you're going to get x-rays, which is perfectly fine. But what is the differential in this kid? What are some of the injuries he could have?
Buckle fracture.
Buckle fracture, good. What else?
There's the Colles fracture, although this isn't necessarily the
Colles
right
fracture, that's for
mechanism.
adults. And that's where, again, a Colles fracture would be where skeletally mature, I should say, not just adults, right? Because that's where you're saying buckle, because that fits with the 10-year-old. Colles fits more with the old person. So,
Doesn't it?
and that's where your x-ray is not going to be as impressive as you want it to be in like an old person falling. What did NICU say?
How about a scaphoid fracture?
Yep, perfect. So don't forget about those. That's where you would, again, your physical exam would help, look more into that. Is it tender over the snuff box? Is it pain with moving his thumb? So a scaphoid fracture is, again, one of those common ones that I didn't even include in here because I feel like everyone kind of knows. Don't miss those because those need to be treated. Again, the key with that would be immobilizing the thumb. So a scaphoid fracture needs to be, and the x-ray is often negative, right? So that's where, again, you got to think about that. Treat them with a thumb spica splint, get the x-ray to see if you see anything, but you're going to keep them in that until a follow-up appointment because x-rays are 50% accurate on scaphoid fractures. And then what's the other one that we talked about earlier? What could he have over his distal radius? Since he's 10.
Oh, like a Salter Harris.
Yep. Which type?
The ER one, type 4.
So rarely answer type 5, the crush one, because it again requires a great amount of force that's more than just falling. So that, again, that would be like jumping out of a second-story building or a car accident. So it would be more likely a type 1 fracture. So again, this is where when you're getting the x-rays, if the x-ray is read as normal, but he has a growth plate, Salter Harris type 1 is diagnosis, right? Because he's tender over that. So it's one of those as a diagnosis. So you splint them and treat them until otherwise. So that's where, again, you won't see that as a fracture like right through the growth plate. But does anyone see another possibility? So again, this is where getting the right x-ray is important because you sometimes miss. So if you worried about the scaphoid, this view didn't get it all, right? So in one way, don't x-ray the whole arm, but in another, if you wanted the wrist, make sure you order the wrist, because if you order the forearm, they might not get the wrist part, they might just get the forearm. So this is where understanding your physical exam and where it's painful. Does anyone see anything, or tell me something else that you would do in this patient if I just showed you this x-ray and said, I know this kid has a fracture? What would your statement be back? And then what else would you say too if again someone is just showing you this x-ray? And it goes back to like the principles of when we're when we're examining patients, and the principles of ordering x-rays.
Get the other view to see if there's any angulation.
Perfect, perfect. So another view would be an absolute, like you can't just get one view, right? So you never just get one view. This is where, again, we usually get 3 views to try to look at it. I don't know if anyone can appreciate right here when, again, someone brought up buccal fracture, which is exactly right. So again, this is where in your mind, knowing buccal fracture is a possibility, this is where on this view, you could see that a little bit of buckling. And then on this view, when you get this other one, you see this big buckle right there, right? And so this is a torus or buccal fracture. Again, x-rays can be hard to see this. And so an ultrasound shows it pretty easily because it's just going to see the little bump. And again, these are those type of fractures that are a fracture, but are not problematic at all from a healing standpoint, a stability standpoint, or anything. So these often don't need anything but a wrist splint, right? And so these are, again, you would never want to refer this to an orthopedic surgeon because they're actually going to cast it, which is a bad thing that all the things say, but they cast because it's easier and they can charge more. And this is, again, where understanding this type of fracture, literally all you got to do is put them in this splint, tell them to wear it for 2 weeks. If it's no longer painful to move, then they're good. Wear it for 2 more weeks to prevent re-injury type thing. And this is one of those, in one paper was like, don't do these things. And one was, do not order follow-up x-rays on these fractures because there's literally no reason to, because these fractures are actually more dense. So like the bone is actually more compressed and will not have a problem. So you do not need repeat x-rays again, unless a new injury, very tender, something doesn't seem right. But on these little tiny buccal fractures are, again, doing less is better in these situations. Does that make sense to everyone? So this one is an example of where you get into you see this tiny little fracture, and this is actually a green stick fracture. So this is where you get the tiny little fracture on one side, but instead of breaking all the way through, you get more of a bending. So then they're pointing here because you see how much the ulna is actually bent. But it bent, but didn't break. So that's where you get a green stick. And these are kind of problematic because now the forearm is all like curved. And so these often need good treatment. And these actually are the type that need to see an orthopedic surgeon usually because the casting has to be right. Sometimes they even have to reduce these. So again, a small fracture, but understanding those big differences can make a huge difference. And one has to be more assessed and the other one shouldn't be more assessed almost. So just throwing in a couple other random x-rays at the end. Does anyone, so if this would be an example where you get an x-ray because this person says they fell and hurt their foot, you get this x-ray and you see this thing. Can anyone describe to me what you would say about this when you're just looking at it?
Accessory navicular, isn't it?
Okay, accessory. So you're halfway right.
Halfway right.
So it's an accessory bone, but where's the
The
navicular?
navicular's over there.
Yeah. So that's a good, at least you understand that why do you think it's an accessory bone? Or why, what if I said, oh, I think he broke it, he hurts right there.
No, because it's all rounded and
Right.
there's no place where it's broken off.
Exactly. So this is that example of where you do an x-ray and then your expectation is to see a fracture. You see one of these common ossicles or extra bones, but just like you said, don't be fooled because it's perfectly rounded. It looks like the rest of the bone. It doesn't fit anywhere. So this is just a bone sitting inside a tendon. That's just an extra one. So you're right. There's a accessory navicular. Some of those are like, there's also the idea that some of these bones don't form perfectly back, but you can see there's osses all over the place. So understanding that these symmetrical things, now they themselves can be problems. So you get this os trigonum syndrome where the ossicle is causing the pain, but that's a different plan and different treatment. And so that's where, again, understanding that these things can be there, but problematic. And this is another example where if someone hurt their knee and then you got this x-ray and they said they heard it yesterday. Well, if you start looking at this and trying to say it's a fracture, look how smooth it looks right there. And then if you look here, this is like someone just basically scooped out that bone, right? And so this is a bipartite patella, which again is a potential for a problem where it hurts right there, but again, not an acute fracture. So again, just kind of understanding that there are those possibilities. And so always taking that into consideration when that doesn't match, like you were saying, it looks smooth, doesn't look like it's out of place. And so one other big thing is if you had like a girl like this, like a 14-year-old was stretching really hard and she felt a pop and she's tender over ischial tuberosity, what would you think about in this situation?
Avulsion fracture.
Good. So avulsion, like we talked about, is a common thing because avulsions, because they're not going to pull their hammy as much as we are, they're just going to tear off the bone. And so these can be very problematic. A lot of times you'll see them in hurdlers or sprinters too. And so this is where, obviously, I don't think you have to know all of these, but understanding that these are all possibilities. So again, when they tell you it hurts here, understanding that the hamstring's attached there, like you were saying, and they can avulse, but there's also these other locations where the abdominal muscles can actually be torn off the iliac crest. So I've seen a few cases of these. This is like telling you which ones are the most common. So again, the anterior superior iliac spine are down here where the hamstrings. But I have seen a couple cases here where their abdominal muscles get pulled off. And these are just the examples. And so you start to see this would be like what hers looks like over here. And this is where understanding too that they happen, but then they can be stable or they can be pulled off so far that they need surgery. So this is where, again, you hope the radiologist would help you. But often the radiologist will miss them because they're so subtle. This is where, again, knowing your physical exam, adding that in, and then ultrasound. So you see the normal, this is one kid that pulled and felt it up on his ASIS. And then this is his normal ultrasound on one side, and then you see the avulsion fracture on the other. So this is the easy way. And this x-ray was read as normal. Again, someone else had ordered it, and then the kid kept having pain. And this is where, again, just trying to say, well, the x-ray isn't the end all be all, but your physical exam is important. And these are where you need to usually do crutches, keep them off of this. And then again, sometimes, again, completely okay to send them to an orthopedic surgeon to decide if they need to do anything else. But again, starting off with the right diagnosis and treatment is key. And then the last couple, this was an example of one x-ray that I got recently. Again, the kid hurt his hand and then was told they got x-rays and then they were read as normal. And then he followed up with me and said he's still having pain. So can anyone think of what we could do better in this situation? Because I will tell you.
Fracture?
Say it again.
Is that a tuft fracture?
Good. Yeah. So these are the tufts down here. So I don't know where you're seeing it, but you might be seeing the fracture here. Is that what you were thinking of?
No, I thought on his fifth digit when he's making the OK sign at the tip of his fifth digit, but.
Over here?
Oh, sorry, first digit, first.
Here. Or here.
I thought the thumb was the first digit.
Oh,
His thumb.
I got you. First, yeah. So this is where this would be where, again, your physical exam would help you because they just showed you all the digits, right? Just like I just got confused with what you were saying. With it shouldn't be, it is, so they got a hand x-ray. When does his thumb even hurt? Like that should have been your first question, right? Like, because if I said his thumb doesn't hurt, then why even put that in the x-ray, right? And so this is where they got this huge picture of all these bones. So the radiologist is looking through. Again, this is a sesamoid fracture, or a sesamoid bone, not a fracture. But again, if his thumb isn't affected, we shouldn't even be looking at his thumb. The problem too is they should be doing an OK sign like that, and they didn't. So this is a bad x-ray. And then the fracture is actually right here, which you can't see on this x-ray. Again, I even zoomed in, but this is where ideally, and now I zoom in and you can see the fracture right there, but to see how it was like covered up. So we should have just gotten an x-ray of his fourth finger. because it wouldn't have been covered up, it would have been zoomed in on, kind of like this one. But this is basically a acute fracture here. But again, the radiologist said it was normal, and so the nurse was like, no, he didn't break his finger. And I was like, yes, he did. And they were like, no, it was normal. And I was like, well, then what is this? And again, this is where taking your physical exam, ordering the right x-ray, splinting them, because again, the main treatment would be splinting. And then the last picture I think I'll show you is this one. And can anyone describe this one a little bit to me? This is actually one I just saw yesterday.
Displaced fracture of the proximal aspect of the distal phalanx.
Good. Does anyone know what this general injury would be? Is if they can't straighten their finger all the way? So they come in and they can't straighten it.
Like the hammer toe, but the finger version, kind of. I
Get a
know.
pond neck,
Oh,
boot. Is there a boot thing? Nope, never mind.
so this is called a mallet finger. But then the one thing here, appreciate if you can appreciate, because this is actually an interesting x-ray, because all this stuff up top is actually healing bone, right? Because his cortex is right there. And so you see how thick it looks up here? And compared to like this guy's x-ray, or looking at just like these. And so he broke it. And so again, this is where he said he just broke it yesterday. And then your question should be, when did you hurt it last time? And he was like, oh, I heard it 3 months ago. So he actually broke his finger 3 months ago, never got it treated. And now we just got the x-ray. And so it's a chronic on top of an acute injury. So again, complicates things a little bit, because you're not going to expect the same healing pattern. But this is the basic one would be a mallet finger where they get hit. Often they don't get a bony component. It's just the tendon ribs. And then the main treatment is just putting them in this splint. So again, a very common one that all they got to do is be put in this splint for 6 to 8 weeks. If they get referred to me, like some of them have, I don't even take them out of the splint, because that's bad, because it detaches the tendon. So I literally just say, that splint feel good? Yep. Okay. See you later. Again, if they have the fracture component, that's where you get into the management of it. And I think that's just where people blend all this stuff, and then it makes it hard to do. Any questions about all that?
There's one in the chat, but
Oh, yeah. Let's see. Oh yeah. So yeah, they were talking about not trigger finger. This is where isn't attached. It's like a Voltron fracture. Perfect. Yeah. So yeah, trigger finger is the opposite, where it's getting attached like in here, and then like you can't move. And this is called mallet finger. So again, that's where I think sometimes the semantics of the words we use, obviously on the test, is important, but in real life, knowing that it's an avulsion type fracture is possible is why you would investigate more and then understand how to basic treatment. And then once it's beyond our kind of capacity to refer them on, because sometimes those need to have like a little pin put in to hold their finger straight.
and then the opposite of the mallet finger is the jersey, it's the
Jersey.
jersey one or whatever.
Jersey.
Yeah.
And then that one on the test, they'll say they can't, they'll try to bend and they can't, because they tore their flexor tendon. And then that one is kind of an urgent referral, because that tendon will retract back a little bit. And so that one does have to be pulled and attached, versus the extensor tendon will just sit there and you can just splint it. So yeah, jersey finger is definitely more of a surgical need for sure. Any other questions? If you guys come up with any, always feel free to call me too, because again, I think understanding some basics, and it's definitely not easy when, again, situationally, you don't have all the right stuff to feel like you can treat them. But
Random story, but there's a lady who got a mallet finger fracture. She was tucking in a bed sheet and like just popped it off.
like
You know,
hooking
like
it
tucking it in like this, and
in,
it,
yeah.
oh,
And then she just came in and was like,
couldn't straighten it.
yeah. And I think those are those are sometimes where just the tendon just comes off, and that is where like adults can get mallet finger type stuff. They usually don't pull the bone off. It just usually is the tendon, and then again just getting the right thing, because sometimes they don't get it treated and then it heals down, and then they're never going to get extended without a surgery. So, well, thank y'all for listening and participating, and I'll see y'all later.